Yeah. So I just wrap around the table, I clip them in. I make this snug, but not too snug. What I like, and I always told my patients, I do want this nice and firm up against his body. I also want him, because I'm going to be doing a distraction technique, I want his shoulder pretty close to the edge, so I'm not reaching so far onto the table. Well, actually, what I'm going to do is I'm going to actually give you a little bit more room. And can you just scoot over towards the end of the table a bit more? That's good. Now just stay right there 1 second. I'm going to make it nice and firm. Now what I'm going to ask you to do is just gently continue to scoot in until this is nice and really firm up against your body. It should only be another inch or two. So if you have the person move the last couple of inches or inch or two, they'll get a nice, very snug fit here, but not feel like they're being like you're anchoring them down, that they're doing it to themselves. And then of course, if this ever gets uncomfortable for them, one of the things I definitely want to think about here is if he starts to complain of any tingling or numbness down his arm, because I'm right there in that axillary region, just scoot over and it'll take the pressure off immediately, okay? But while he's there, now what I can do is I can come in, the scapula, notice, now this is what people get wrong all the time on practicals, and that I'm wrapped around his thorax, his scapula, and got his scapula down. Guess what many people do on practical exams? They go right over and down underneath the table. So then the belt is in no way contacting the person's scapula, right? You can't do that. I anchor to the table, whatever that looks like, however I need to go around that, but you want the belt around the person's thorax, right? So we can stabilize that down. So now that I know the scapula is not going to move, I'll come in. This is the exact same position. It is the exact same technique as when I did my joint mobility assessment for distraction, except now what you're going to notice is it gets tight very quickly, right? It really doesn't move at all. And so now I'm feeling, and I'm thinking, the one we want you to think of is those Kaltenborn grades. Remember Dr. Bertrand talked about that in the first week. This is where it's going to come in. It's going to come in again and again and again at every single mobilization we do in the classes. I'm going to take that joint. You got your arm there for a second? And if it's getting uncomfortable, do scoot in just a second. Okay. I'm going to take her joint until it doesn't move anymore into that first stop. Then I'm going to take it a little bit forward to where I get to that physiologic end range. And then once I'm there, I am going to push even further into that microfracture region.
Will you feel three distinct?
You'll feel it tighten up, and you'll feel it get very quick. Like you're like, all right, I'm going in, then all of a sudden it's like, oh, it kind of stuck there. Then you can pull a little bit harder, and then it'll feel like you'll give it a little bit more, and maybe it gives ever so slightly, and then all of a sudden it'll be like, man, that really doesn't move anymore. And then once you're there, that's when you want to give it a little bit more if you can.
Okay.
Okay?
It's going to be painful, so I'm going to say, ow.
No.
I'll let you know.
Nope. He'll let you know. I've never had anyone tell me ow. I've had people tell me ow when I'm using these, and because you'll see in a second, and when I'm pushing on them, maybe that's uncomfortable because of the pressure of a spot, and then we just move this around or shift it, and then it's like, okay, no, that's fine. I've never had anyone complain of pain when doing the actual joint technique itself. Okay, so I just come in, and again, I'm going to see where is that. So that's like that first end. There's that second end right there, and then I'm just going to go into it just a little bit. And hold for how long? 10 to 15 seconds or so. And then when I'm done, I come off. And I might do that 3 to 5 times. And just hold it. Again, going in that superior lateral anterior direction to get the distraction. Okay? Excellent. You can scoot down a little bit. Okay. The next one that you use the belt for is the inferior glide. So I'm going to show the inferior glide next because we already have the belt on. Now, I'll show you guys a little trick. Scoot on over to the edge, just like you did a second ago. Okay. Remember, when I do an inferior glide, I don't want to just push inferior, but I want to push inferior and slightly lateral. Okay. So I can do that here. And if it's for abduction, remember, when we do assessments, they always have to be in the open pack position, right? When you do your mobilizations, you don't have to be. You have freedom. You can move around. If I'm trying to get more posterior glide internal rotation, I might put the person into an internally rotated position while doing that mobilization. If I'm doing an inferior glide for abduction, I might actually stand above them, take them to their end range of abduction, and then from there, push slightly inferior and lateral. Okay? So remember, the glenoid sits like that. Okay? A little trick you can do with people is, what if I change his body position so that way I could push straight down to the table? What would I have to do with him? Yeah. Can you just scoot your hips and body, lower body that way and lay more crooked that way? Now the glenohumeral joint is sitting, instead of sitting like that, has been moved to like that. So now actually, because he's in this position, I'll be able to just scoot like a whole body straight into that a little bit tighter. Perfect. Now, instead of having to worry about going lateral, for me, I can just push straight down. It's still slightly lateral to him, to his body orientation. But for me, and the orientation to the table and the body and all that, this becomes much easier for me this way. I can just go in and just do that little bit of a, just kind of feel that end and then take it into that end right there. And I would hold it for a prolonged period of time. Since I'm not interested in creating hypermobilities and all that in your shoulder, I'm not going to do that for 15, 20 seconds each time, right? So those are the two mobilizations for the glenohumeral joint that you're going to use the belt for, the distraction and the inferior glide. For the posterior and anterior glide, you can scoot over and we'll take this off of you now. We're going to get to the wedges. Wedges they do come in different shapes and sizes. It's probably the most common one that you see out there, the blue one. But I've seen red ones where maybe they're not as steep, they're a little bit more shallow, and green ones, and there's different ones out there. They generally have the two sides. They have the flat surface, and then they have the surface with the canal in it. By and large, in this class for this semester, you're always going to be using the flat side. This side becomes more pertinent when you're doing maybe spinal mobilizations. The spinous processes can sit right there. So that way these articulate with the transverse processes and hold the transverse processes down while you're trying to maybe mobilize the back in a certain direction. So use the flat side. And if I'm going to do a posterior glide, so I'm going to go posterior slightly lateral, which way is his scapula going to go when I push with that? It's going to go backwards and out with me, right? So I want to stop that from happening. I want to stabilize it, right? So what I'm going to do is I'm going to place the wedge on the table, okay? I am going to at first, and scoot more over to the edge of the table. Again, the closer to the edge, the closer to me, the better. At first, I'm going to kind of guesstimate where that glenoid is, okay? I do know it sits like this. So if you look at the way my wedge is oriented on the table, it's oriented a little crooked here, not straight. Okay? But what I'm going to start to do is, now that he's in this position, I want to get a good appreciation for where exactly his glenohumeral joint is. So I'm going to start rotating his arm up and down and really kind of get a fix on where I feel that glenoid is. And then what I want to do is I really want to try to match the wedge to where that line is in my mind. And for me, I think I've got this way too in on him. Okay? So I'm just going to pull it out a little bit. I'm going to pull this out and come on back down. Okay? And once again, I just want to make sure I'm looking to get that wedge as close to in line with his glenoid as I possibly can. If I'm too far in and I'm pushing down, his scapula is going to be tipping. If this is the wedge and this is his scapula and his glenoid is this edge of my finger, he's going to be tipping right over that. Or all that pressure is going to be right on that one spot. Conversely, if I overshoot it too far, the wedge is too far forward, then the humeral head is just going to hit it, right? So I got to get that really right on line as best I can. So what I'm doing is I'm just kind of using my fingers. I'm taking them through some flexion and extension. I'm trying to feel where is that humeral head and where is that glenoid as best as I can estimate it, and then try to make sure that this wedge is in line with it. And I think I took it too much this way and a little bit too far out. So I'll do my best with that. Once I'm where I want to be, then I can go ahead and do the mobilization. And like we said before, it's not going to be straight down posterior. It's going to be slightly out and lateral, right? Also note, because the wedge is under there, what did I do to his scapula? It's not as flat anymore, right? So it was like this, but now it's like that more. So I probably need to be even more lateral now than I was a moment ago, okay? And that's only because you can see the change in position for a scapular on this side versus this side now. So where before you were going slightly lateral, you might feel like you need to go even more lateral only because that wedge is there. Again, what I'm going to do is I'm going to take him to where I feel like that's the end range of his motion, and then I'm going to go into the plastic range. Just a little extra overpressure. How's that feel?
Good.
Feels good.
It's tight.
Feels tight. We're loosening it up. Okay? Good. Posterior glide. The last one's anterior glide. Probably the one I use the least in practice, but we're going to go over it anyway. So when I do the anterior glide, okay, I need to go anterior and slightly medial. Okay. So I have a couple of options. I can try to tie down his shoulder here and physically lift his arm anterior and medial, but with the amount of force I need to put, is that very efficient? No. So whenever possible with these joint techniques, you always want to be pushing and always going with gravity. So to make this technique push and keep him in gravity, what do I need to change? Lay him on his stomach, right? So let's get you on your stomach. Now, just for purposes of demonstration, we're switching arms, right? I mean, if I'm working on this person's left arm and that's their problem, I need to go to the other side of the table, right? But I'm not going to do that here. All right. Now, the orientation of the glenoid has changed. It's here now. It's different. And that's why we got to do the anterior medial direction, okay? So what I'm going to do with the wedge, again, I want to stabilize this as best I can. I'm going to place it on the underside of him. You can relax. So that basically his clavicle, you can kind of see where that's supported there, just like that, okay? Again, a very important key feature is where is that glenohumeral joint line? Same problem. I can't be too medial, but I don't want to be too lateral either, okay? I'm just going to sneak that in just a smidge. Go ahead. Okay, all right. Once I'm there, again, if his problem, he's got pretty good glenohumeral motion, it gets to here, and that's where he starts getting tight, I might take him to that point, just back off a little bit to give him a little bit of room, and now the mobilization is going to be anterior and medial. How's that feel?
Good. I feel like I'm hitting that.
Yeah,
actually.
move that in a little bit. I'm about to say the exact same thing. It's like, it doesn't seem to go much, and it feels very firm right away. That feels better, right?
Mm-hmm.
There you go. So anterior medial. If he doesn't have that much extension, if he's down here, I might need his arm a little bit lower while I'm doing the mobilization technique. Again, when it comes to the mobilization techniques, the interventions, you don't need to be in the open pack position, that rest position. You can get away with being out of that position. What is the one position you cannot be in? Closed pack position. Do not put the person's arm in the closed pack position and start doing that. That gets pretty close when you're doing inferior glide and you're trying to get the last few degrees. You're kind of right in there, right? So if you want to, you're working on ab